very prolific retina surgeon. And our group is from Kanpur. This whole concept started from Kanpur only. When Dr. Lalit Verma came, we called them and we said that we are doing a CME with difference. Then he asked, what is the difference? So then he suggested that you go ahead and make up this program. So Dr. Mohit is another fellow friend of us who is doing a fantastic retina work in Kanpur for last almost more than a decade. And he will be telling about a very important subject, how to strategize to do screening and what are the future what we are going to do. Yeah, Mohit.
Thank you, sir. Good morning, one and all. It's a blessing and a blessed moment today that we are here in this hall in AIOC for discussing human analog for artificial intelligence. I thank AIOC office bearers and special thanks to Dr. Mohit Khattar sir for conceptualizing this course and taking me along with him for last 4 years. So I've seen this baby growing, and this is second national forum where we are talking on the same topic. What section has been given to me today is slightly different and difficult. What I mean to convey is where we stand in understanding AI, what are the international standards we have achieved, and what pitfalls are there in AI so that we need to improve or incorporate something beyond AI. When we talk of humongous volume of diabetes in this planet Earth, we see that 422 million diabetics are already there, and we project to be having 640 million diabetics in working age group by 2040. And see this mismatch. We have 1200 trained vitreoretinal surgeons in India and estimated 3.5 million referable diabetic retinopathy on this very date in India alone. Now, this demanded a lot, and the whole corporate jumped into development of different tools for screening of diabetic retinopathy. We had fundus cameras, handheld fundus cameras, mobile coming in, lenses modification and whatnot. Now basically what we incorporated here is two modes. First is a fully automatic mode where there are sites of absence of a reliable graded or an acquired for all acquired retinal images, and all the referred images are screened by an ophthalmologist, and at least 10 non-referred images are to be screened by an ophthalmologist later. Another one is an assisted or an augmented intelligence mode where there is an ophthalmologist per se and the images are screened by an ophthalmologist and graded for the diabetic retinopathy status. What basically is this artificial intelligence? See these two pictures. First is supervised learning. You give input data of apple and tell that this is apple. So the machine identifies, yes, this is apple. So you supervise the machine. But then other is an unsupervised learning. When you give lot many fruits and then you develop the neural networks which at least strategize or categorize apples, bananas and other fruits in different categories. So this is what is an unsupervised learning. So what we can do is generate lots and lots and lots of reference images and develop the neural networks mainly by regression analysis so that the machine identifies what you want to convey. This is what is the whole concept of artificial intelligence. Now what this current status is for all AI models. There is something called eye grading, ret marker and IDXDR, and they have been found very much comparable with the results what trained persons were giving. IDX got US FDA approval in 2018 and was the first to get so, and later on IART system got approval in 2020. Google, having an Indian CEO, was very much interested and knew about the burden of diabetes, and so they collaborated with Shankar Netralaya Chennai and Arvind Eye Hospital Madurai. From there they got the reference images, and big projects are running with coming results every year. Now what is this IDXDR? Here the images were captured through non-magnetic TopCon camera. There were two images being fed into the camera. First was optic disc centered, another was macula centered. The reference images what IDX was getting was through Wisconsin Institute, and it gave two results, either more than mild DR or less than mild DR. Simple. If it is more than mild DR, it gave a command to refer. If it was less than mild DR, it gave a command to screen after 12 months again. Reference images, Dr. Malay has already shown, they were ETDRS level 35 with the sensitivity and specificity of 87.4 and 89.5. And it is very interesting, the last line is an interesting line, that if we talked of level 43 and above, the success rate was above nearly 100%. So now what these pictures are, they have been discussed already. This table, need not to see any of, this is the evolution of AI. You see, earlier it was only 143, 60, 30 images being studied. Very few, the sample size was not very high. So this is how the results were evoluting, and then you see a huge study coming here. AIOC study and Ting from Singapore. These are the largest studies that came upon, and then they gave the real insight that yes, we can do something with AI. Then, recently, if we talk of last 5 years, what we have achieved are these studies, and Gulshan is the person from Google who really worked with Shankar Nethralaya to get these results, and now we have from 2016 and 2019 work coming from Arvind and Shankar Nethralaya through Google, and this is what we have. Interesting thing in this whole slide is positive predictive value. See, after spending billions of dollars, the positive predictive value is around 50%. This is the key point. So what are the challenges with AI? First and foremost challenge is retrospective and prospective study. All what we are getting from AI is a retrospective result. And unless and until we do a prospective result, if something ajeeb say, you never know what comes the next picture. Machine doesn't know that picture. So machine falters. So we have to be prepared with our gray matter, that what surprise you can have in a patient. Patient is always a surprise box. So unless and until you conduct a prospective study, the results are never going to be natural. Accuracy never means equivalent to clinical efficacy. Machine can be equivalent with what? What is accuracy? What you have fed, the marks are going to be given with that only. So accuracy can never be equivalent to clinical efficacy. Then you cannot compare. Somebody is using this algorithm, somebody is using that algorithm, somebody is giving data of European population, somebody is giving American population. So you cannot compare apples with oranges. No. And machine learning, sometimes there is data set shift, sometimes there is a bias, sometimes there is inapplicability, confounders. So many things come within the machine. Logistical difficulties are also there. There might be cataract, there might be poor acquisition of image. The skill of photographer also comes into role. So not all data in healthcare system is available for machine learning also. You discard many images, but do you need to discard them? They were really diabetic retinopathy and you discarded, so that's not done. So how there has to be big bodies to regulate and quality control, that is still not there. So the baby is still small. This is what I am wanting to say. AI systems fail till date to explain in an understandable way the decision making. So if you have detected moderate, if you have detected referable VTDR, now what? So there is nothing in AI to give you the answer of now what. So the decision making in AI is still very much deficient. So human versus algorithm. The biggest question is, if you keep getting answers from machine, yes, refer, yes, refer, yes, refer. So after 5 years or after 10 years, my question is, did you really reduce the visual disability or you just increase the warning messages and recall rates? You don't know. So there has to be some policy principles. These researchers need to be human-centric, very transparent, ethical and social regulation should be there. And there have been an infancy stage of task forces being developed like Consort, Spirit, START. They are giving standardization to all the AI reporting guidelines. So we are coming up with these things. Organizations are working. WHO, as Dr. Malay said, US FDA is giving approval after some regulated authorities like Radiological Health, Digital Health Center for Excellence, and G20 AI principles are also coming up with the design of policy actions. So now is the role of human analog. There are 1200 trained VR surgeons, but AIOS has 22 ophthalmologists registered. Human brain, I bet, can have more neural networks than any neural network you develop through any analysis in Google. The least infrastructure required is there in our cranium. We can utilize that. It is easy to regulate, supervise, and improvise. And as beautifully depicted by Dr. Abhijat, we have been doing it for last 4 years. So why can't we do it more on a larger front? So let's ponder. Beautiful work done by artificial intelligence people across the globe. Something machine dependent has come. But just blink your eye and think once again. Can we think beyond machines? Can a human analog be developed? Can we learn here in our brains rather than feeding so many things into the machine and finding out the errors? So this is the thought to be had here in this hall. Thank you all for your attention.